and welcome to another topic in salivary gland pathology. Today we'll learn about sialolithiasis. Sialolithiasis. Now, if you look at the term sialolithiasis, silos suggests that it has something to do with the salivary gland, and lithiasis suggests stone. So basically, stone in the salivary gland, or it can also be stone in the salivary gland duct. So stones can be seen in the duct as well as the gland. So we'll go into detail regarding sialolithiasis. Now, sialolithiasis, from the term itself, as I mentioned, it is something to do with stones. Just like you get kidney stones in the kidney, you can get stones in the salivary gland. It's not uh, usually seen, but then it's not rare either. So it is possible that you might be able to see it in the common clinical practice also. So you have to recognize this particular lesion or this particular condition and plan steps to do the treatment for the same. So first of all, you have to recognize what it is, recognize the clinical features, and then possibly what are the treatment modalities that we can do with sialolithiasis. So sialolithiasis basically are nothing but calcified structures that develop within the salivary ductal system. Not only in the ductal system, sometimes it can be seen within the substance of the gland also. So it is thought to be due to the deposition of calcium salts in the duct, and calcium salts usually will deposit around some starting point, that is usually a nidus. What do you mean by a nidus? Nidus is something, a small minute, it could be a minute debris, it could be some hardened mucus or inspissated mucus, it could be a dead bacteria, or it could be foreign body. So what can happen is that calcium will form around this initial starting point called as a nidus, and it keeps slowly accumulating. So slowly starts increasing in size. Gradually it can fill up the whole duct, and it can be a complete blockage also. So initially it might be a partial blockage leading to complete blockage of the duct. Now this can be exacerbated by, if the salivary gland is having some, or it is affected by some infections, and even partial obstruction as such can lead to uh, the complete formation of this sialolithiasis and completely blocking the duct. What are the clinical and radiographic features? Now, it has been observed that most commonly these stones develop in the ducts of the submandibular gland. Most commonly in the ducts of the submandibular gland. And why is that? It could be due to three reasons. One is that it is having a long tortuous course. The duct starts from the posterior aspect almost along the length of the edge of the mylohyoid, and comes forward and anteriorly towards the frenum of the tongue and opens there. So it has a long tortuous course, so that can be a possibility. So anywhere along the length of the duct, the calcifications can occur. Second reason could be is that it is having more of a viscous saliva. So it is possible that saliva movement could be slow along these ducts. And again, one more reason that is given is that it has to work against gravity. Saliva has to work against gravity to finally emerge in the oral cavity. So that is these are the three possibilities that can occur, or that has been suggested that why this sialolith is occurring. So this is usually seen in the submandibular gland duct. Not necessarily that it's only seen there, but it can also sometimes be seen in a minor salivary gland also. And again, age group usually seen in not in children, more in the young and the middle-aged adults. And what are the symptoms? What does the patient complain of? Patient complains that certain periods of time, there is some sort of a recurring pain, some sort of episodic pain. So due to usually he feels it when he comes and sits down for his meals during meal times. It is, he's having more pain. Or sometimes when he thinks of food, he can have pain. So that can give you a clue that it could be something related to a stone within the duct. Now, the pain as such will vary according to the obstruction that is seen in the duct. It can be, if it is a partial obstruction, he might be having slightly lesser pain, but if it is a full obstruction, naturally due to the back pressure exerted by the saliva, naturally the pain can be more intense. Okay, and as a dentist, you can be able to palpate these stones along the duct, especially towards the terminal portion of the duct. And the usual radiograph employed is the occlusal radiograph, where you can see uh, the radiographic mass along the length of the duct. So usually the occlusal radiograph is used for the submandibular gland duct. Now the question is whether the minor salivary gland ducts, the minor salivary gland sialoliths, do they cause any problems? It has been it does not cause that much pain, but then you can observe that maybe in that area where the sialolith is there, there can be some sort of tenderness. There can be more of a redness in that area, and a slight swelling of the affected gland may also be noticed. So that can be a clue that it's some sort of problem is there. And already we know that sialolith in minor salivary gland can cause a cyst formation, isn't it? The cyst formation is the sialocyst or the mucus retention cyst can be caused due to this sialolith in the minor salivary gland duct. So that is also possible. So this is the radiograph, this is the clinical photograph. You can see the extruded sialolith from the duct of the submandibular gland. It is extruding out, somewhat yellowish in color. So this must be almost at the terminal portion, so it can easily be taken out by the dentist. And you can observe that it is more cylindrical because it takes the shape of the duct. And this is of course the floor of the mouth, and this is the tongue for reference. And this is of course the occlusal radiograph taken of the mandible, and you can see the mandible as such along with the teeth. And can you observe the radiograph showing the radiopaque mass? So this is the radiopaque mass along the length of the. So this is along one part of the duct. So this is along. You can see that it is in one part of the duct, the sialolith. So this is the radiopaque mass that is seen in the duct. Going for a biopsy or histopathology, what can be noticed? First, of course, if you take out the sialolith and observe it, you can see that on a gross examination, these stones are really hard masses, and the shape can vary from round, oval, or cylindrical, and the color can be yellow to brown. And again, the submandibular gland ducts, the stones in these submandibular glands are sometimes or usually can be seen to be larger than that seen at the other side. So submandibular gland stones or the submandibular gland duct stones are observed to be larger than any other stones in the oral cavity. And biochemical examination or of the stones have shown that it's made up of calcium phosphate and calcium carbonate. And microscopically, if you cut the stone, you can see a calcified mass, and the calcified mass is having some sort of a concentric laminations around the central nidus. So remember that initially there will be a central nidus, and the nidus could be anything like a hardened mucus. Like it could be bacteria, it could be discovered epithelium, it could be debris around which the calcium will accumulate and form laminations, and it slowly it can fill up the whole of the duct. And the ductal epithelium might show some changes. It might be squamous epithelium. It could be some sort of an oncocytic change can be seen, or it could be there could be some sort of a mucus metaplasia also can be seen. And it has been observed that around the duct there is some sort of inflammation. There is some sort of inflammation around the duct. We call it as periductal inflammation. Now, this is the histological picture or the photomicrograph. So here we can observe the stone as such. This is the ductal epithelium. So this is seen occupying the full ductal area, or the full duct is occupied by the stone. So here we get a full obstruction. And you can notice that this is the central area. Here there might be the central debris. Around this, you can see the laminations made by this is the calcification made by this is the lamination made by the calcifications. So more and more calcium is being deposited around the central nidus. And you can see that it is fully occupying the ductal area. And this is the ductal epithelium. And as already mentioned before, the ductal epithelium can be as squamous in nature, or it could be oncocytic, or even mucous metaplasia may be seen. And around this area, just above the ductal area or the epithelial area, you can see some sort of inflammation is also present. So that is the periductal inflammation. Now, how do you go on treating this sialolith? So, if it's a very small sialolith, usually conservative treatment is enough. But otherwise, a little more larger ones, what can be done is ask the patient to take more fluids, maybe prescribe some sialogogues, and apply some moist heat in that area so that it can promote the passage of the stone, and it might pass out on its own. But it is difficult for larger sialoliths, in which case they have to be removed surgically only. Larger sialoliths has to be removed surgically. And of course, there's a very good prognosis after removing the stone, and the patient will be free of all this episodic pain when you remove the stone. So that's about sialolith, very interesting lesion or a condition that is seen in certain patients, and you might come across such cases in the routine clinical practice also. So be aware and know how to recognize the clinical symptoms, signs and symptoms, the radiograph that has to be taken, and how to manage it. So thank you very much for a patient hearing. Thank you.